To really set the stage for us. I was hoping for the Dr. Evil $30 billion, but not quite. So while we fix the hopefully fix the slides here. Yes. Thank you very much. Just plugging something in. We're not electricians. Okay, so in the Immature, old high school friends receive a letter from the Ministry of Education. Because of a formal error, they must retake the examination. In Big, a boy wishes to be big at a magic machine, Zoltar, as you all know, and wakes up the next morning to find himself in an adult body. Tim Clark, who's kind of like a little guy in an adult body, I can afford to do that, from Philadelphia, is here to tell us how to handle fistulae that have not yet graduated to use using the magic of IR. Tim?
Thank you, Scott. Thank you, Gordon. Thanks for allowing me to be part of this session this morning. So it's important to know that from our most recent best available data, including prospective randomized trials, these trials have shown up to 62% of surgically created fistulas never mature to the point that they can be used for cannulation. So this results in prolonged catheter dependence for these patients. Their venous conduit that was used to make the fistula is now depleted. You have to go from the forearm to the upper arm, or from the arm that you're in to the contralateral arm, or from there to the chest wall or the thigh. And the fistula, with it not maturing, then gets abandoned, and often in favor of a surgical synthetic graft, which, as we all know, confers higher infection risk, higher thrombosis risk, and decreased long-term outcomes. So access patency is what portends survival in these patients. And really, what we want to do is preserve access patency with the fewest number of interventions, unless, as we've heard, if you're in an outpatient center. And that confers high quality of life, low cost, and therefore that is appropriate, cost-effective health care. And the immature fistula population is where we can really bring these factors to bear based on our expertise. So I just want to take a couple of minutes to how, with our current evolution of our understanding of how these patients should be approached, what is your go-to guide to salvage these patients? Well, first of all, you've got to evaluate the patients all the way from the artery to the right atrium. Expect there are multiple stenoses. These are not grafts where there's an outflow stenosis, you balloon it, or maybe there's some recoil, you use a bigger balloon, then you're done.